Welcome to the Foundation for Women and Girls with Blood Disorders inaugural symposium. Our foundation was organized 2 years ago with the mission that all women and adolescent girls with blood disorders would be correctly diagnosed and optimally treated at every life stage. Before we move on, there's a couple of housekeeping details I'd like to we take care of. One is our staff will be coming around and making sure that we have your pre-tests, and then I'd like you to remind you to turn off your cell phones or put them on mute, put your pagers on mute, and no flash photography. We already have plenty of bright lights right here. There's a few people we'd like to acknowledge. We'd like to acknowledge the help of our medical advisory committee in getting us launched. We have expert advice from a number of medical specialists across disciplines, including internists, pediatricians, family practitioners, obstetrician gynecologists, pediatric hematologists, adult hematologists who represent multiple disease states. And I would also like to acknowledge the sponsorship of two sustaining sponsors who have made our educational programs possible, and they include CSL Behring and the Hemophilia Center of Western Pennsylvania. Thank you. Our mission is to help educate providers about the unique needs of women and girls with blood disorders. And the way we intend to do that, to begin with, is through webinars, symposia such as these, and our website, fwgbd.org. The easiest way to find it is go to Google and type in Foundation for Women and Girls with Blood Disorders, or any combination of those terms, and it ought to come up. And we hope to provide you with resources, state-of-the-art, and an interactive site where you can also tap into our experts and get timely responses regarding the management of problems related to their unique needs. This morning, our moderator and first speaker, I'm honored to introduce. She's one of the members of our board of directors. It's Dr. Roshni Kulkarni. She's professor of pediatrics at Michigan State University, where she is also director of pediatric and adolescent hematology oncology. She's director of the the Hemophilia Treatment Center there. She's the former director of the blood division at the Centers for Disease Control, Dr. Roshni Kulkarni.
Well, thank you very much and welcome everybody. I can't see anyone because of the bright lights are in my face. However, what I'm going to do today is just kind of give you an overview of women with blood disorders. And the idea is to see the commonality, and I'll put a plug in for the CDC's conference on blood disorders, which is going to occur in March 12th to 14th next year, 2012, and I urge everybody to come. They're a great program, and we should really thank Dr. Hani Atrash, Mike Susi, Chris Parker, and others at CDC who have put this wonderful program together. So please, it's on the web, cdcblooddisorderconferences.com. So please go ahead and register yourself for that. And these are my disclosures, really nothing pertaining to this talk. And what I'm going to do is give you an overview of blood disorders. And this will be followed by Dr. Jennifer Dietrich. She's a pediatric gynecologist, one of those rare people and who has great insight. She's also a member of our board. And then managing women with chemotherapy-induced thrombocytopenia. Just a great topic by Dr. Peter Quides, who's on our advisory board. Sickle cell disease and menstrual issues, and with Dr. Kim Smith-Whitley. And finally, a contraception for women with a history of thrombosis. So these are really issues that we feel are important in women and challenge just not only the pediatric hematologists, the pediatric and adult hematologists, but also OBGYNs and others, or primary care physicians who take care of these women. So why should one study women and blood disorders? Well, clearly, early identification results in prevention of complication. And then, of course, you have to determine the burden of disease and quality of life impact, and improved understanding of maternal and fetal outcomes. As a pediatric hematologist, clearly the fetal and neonatal outcomes are very, very important because it impacts a lifespan of a person. And then provide provider awareness, and clearly the awareness should result in accurate diagnosis and treatment. So today we are going to cover some of the topics. There's a whole host of blood disorders which are common in women, and I don't think we have time in this session to cover all of them. The ones listed in blue are the ones we are going to hone in on a little bit, and perhaps at other conferences we will cover some of the other issues. So for example, we have Dr. Adriana Vlachis, who's an expert in bone marrow failure syndromes and very interested in women's issue. We are delighted that she's here today, and hopefully we can have a little bit more insight into some of these problems with not only just sickle cell disease, but thalassemias and other anemias. I think anemias is a huge problem. So what are the issues regarding blood disorders? So menorrhagia and anemia are the most common presentation. And from a hematologist perspective, many of these women get exposed to blood and blood products. And so is there any way we can avoid those? Can we provide them better treatment modalities so as to avoid surgeries, unnecessary surgeries, and unnecessary exposure to blood and blood disorder? This group is really not a well-defined group. There is no single advocacy group. So now, for example, some of the advocacy group take care of bleeding disorder, thrombosis, others take care of sickle cell disease, etc., but there is no one group who speak out for women and girls with blood disorder. Many of these women, both in this country and in other countries, relate better to female physicians, and they want to produce a reproductive life. The other major problem is with diagnostic issues, and very few centers have diagnostic capabilities, but the diagnosis itself is very complicated, requiring repeated testing. Personal issues, and I should just tell you that I met a physician, a hematologist from one of the emerging countries, developing countries, who had von Willebrand's disease and had heavy menorrhagia. A month after she was married, her husband left her because of bleeding problems. So she's now become a spokesperson. But I think a lot of these women are unable to kind of defend themselves against these conditions and undergo great personal challenges. Besides that, there is an impact on children, not only in increased mortality and morbidity, but also these women giving birth to affected children. So there's this whole guilt, etc. Because the mothers are affected and can't provide care, many of them have poor schooling, poor nutrition, and in many developing countries enter labor force at an early age. So what are the lifespan issues? So when you look across the lifespan, what do you see? Well, as you can see here, majority of the problems, whether it is bleeding disorder, clotting disorder, anemia, sickle cell disease, are concentrated in the adolescent and childbearing age. And you can see menorrhagia is very common, both acquired as well as inherited disorders causing menorrhagias. And anemia leads to postpartum depression, intrauterine growth restriction, fetal deaths, et cetera, and of course sickle cell disease is associated with delayed puberty. Just last week I had a patient 15 years old with sickle cell disease who hadn't started her periods, and this was a great concern to her and her parents. What you see here is really what is lacking is more information on what happens in the perimenopausal and menopausal period. So even though I'm a pediatric hematologist, I kind of advocate for doing more research and having more information on what happens to these affected women during these periods. So what are the types of, I'll go over a little bit about each of these disorders, and a lot of the information has come from the CDC, and I'll present that to you. Von Willebrand's disease, hemophilia carriers, and platelet function disorders are perhaps the three most common. The rare coagulation disorder, even though they are rare, these are women who get really exposed to blood and blood products, and we currently have some products that can be used in these patients. And there are other disorders, and I remember meeting the people from the HHT Foundation when I was at the CDC who really wanted to bring awareness to this issue throughout the hematology community. And Ehlers-Danlos syndrome is another of such rare disorder. Recently lost a patient, a girl, who not only had heavy periods, joint bleeding, but died from narcotic use for her severe pain secondary to Ehlers-Danlos syndrome. So female and blood disorders are a public health concern because about 12 to 20% with women or women and girls with heavy menstrual blood loss have an underlying bleeding disorder. Now, CDC did a couple of studies years ago, 2003 and 4, where they demonstrated that it took 16 years from the time of signs and symptoms of menorrhagia to a diagnosis of a bleeding disorder. And I think that is inexcusable in this day and age. And it affects all age groups of girls and women and adolescents, and associated with significant bleeding and decreased quality of life. The WHO estimates that 18 million women worldwide have menorrhagia, and postpartum hemorrhage is a major cause of maternal mortality worldwide. At the government, the Healthy People 2020, which is a template, and thanks to the efforts of Dr. Hani Atrash and the NHLBI, they have for the first time put in these issues in this Healthy People objectives, that the idea would be to increase proportion of providers who refer females with symptoms suggestive of inherited blood disorders, and increase proportion of women with von Willebrand's disease who are timely and accurately diagnosed. So we hope we can reach these goals. In order to know about women in bleeding disorder, and I'm not going to go into detail about this, you have to know what is a normal menstrual cycle and what is a heavy menstrual period, and some of the other speakers might cover this a little bit. Just to briefly tell you, begins between 11 to 12 years of age, and or 14 years of age, and cycle duration is anywhere 21 to 45 days. And I think there are screening tools, and Claire Phillip, who's in this audience, has really done an outstanding job in demonstrating the importance of using serum ferritin and the pictorial blood assessment chart of blood loss during the menstrual period as being very sensitive tool. Now, I understand in Canada, some of these tools are used in pediatricians' offices and family practice offices to diagnose or at least to do a preliminary screening. And Dr. Maggie Ragney is doing a study in children. And I think I commend that, because what that means is we can diagnose these patients really early so we can give them appropriate treatment. So what is the prevalence of menorrhagia in women with bleeding disorders? So you can see it varies anywhere from 10% to 100%. So there's a wide range. And what is the prevalence of bleeding disorders in women and adolescents with menorrhagia? And you can see that it varies anywhere from less than 1% to as much as about 44%. So both ways, so either women with bleeding disorder have a very high incidence of menorrhagia, and women with menorrhagia, not all of them may have a bleeding disorder, but then you should think about a bleeding disorder when you encounter a patient with menorrhagia. This is the number of females in the US hemophilia treatment centers And you can see the numbers went up. In 2002, it went down because the definition of an active patient changed from every 2 years to a yearly visit. But still, what is important here is the numbers are still going up, and we see a lot of these women in these centers. The CDC, under the leadership of Peter Quides and Vanessa Byams, did a study called the Female Universal Data Collection, and there were participation from 20 centers, about 1 to 2 per region. And there were 319 patients in this study, and the most common bleeding disorders were von Willebrand's disease, hemophilia, and platelet disorders. And what is important, I'll just highlight some of them, is that 51.5, a little over half, were below 13 years of age at diagnosis, majority were Caucasians, and family history, and this is what I stress to my students and residents, it's family history, and family history, 60%. And you can see history of anemia, 44%. So what does that mean for us clinicians? I think if you see a woman or an adolescent with a bleeding disorder, please do iron studies, because that is an important, and as Claire Philippe has shown, I think if you add that to your pictorial blood assessment and a bleeding assessment tool, that is a very sensitive indicator of a bleeding disorder. The referrals, very interestingly, were mostly by pediatricians, hematologists, and family practice physicians. So what does that mean to us as a foundation? It means that this is the area where we should hone in for provider awareness and education, and that is what we hope to target. If you look at all the results, and I'm not going to go one by one, the most common one, as I mentioned, 61% were type 1 von Willebrand's disease, 40% factor VIII carriers, and about 4.7% were platelet disorder, not 40%, but 12.5%. And there were other disorders which were also pretty common. And if you look at the frequency of bleeding symptoms, and they varied all over, and menorrhagia, I've highlighted that, is about 76%. The other varied anywhere between 40 to 50%. Many of them required provider intervention. So that is an important key point. Now, when you look at the frequency of bleeding symptom, and I compared this with the CDC study by Dr. Kirtawa in 2004. The study was specifically looking at von Willebrand's disease. As you can see here, a lot of them had a lot of bleeding problems, such as nosebleeds, menorrhagia, bleeding after surgery, and pregnancy and postpartum hemorrhages. And when they looked at gynecologic abnormalities, you can see that besides dysmenorrhea, there were other things such as endometriosis, fibroids, uterine cervical polyps, and cervical cancer. And the importance of this is a lot of these women, in my own practice, when I see these children and talk to their mothers, oh, are you having heavy periods? Oh no, I underwent hysterectomy at age 35. And that to me is like, wow. I mean, that took care of your uterus. What about the rest of your body? What happens if you bleed with cholecystectomy or a fracture or a trauma? I hope you never have it in your life, but if you do, you really need to know so that you can take care of it. And then suddenly a light bulb goes on saying, oh, you're right, if I bled from my uterus, I could bleed from anywhere else. So here are the frequency of pregnancy outcomes, and I highlighted the ones that bleeding during miscarriage, pregnancy, and postpartum hemorrhage are seen in anywhere between 76% to 37%. And when you look at the treatment modalities, oral contraceptive is the most common one, and you can see that not a whole lot of them, and I think we'll have to tease this out a little bit more, saying how many of the von Willebrand's patient used factor concentrate versus, or the factor VII deficiencies, et cetera, where there are others. Levonorgestrel is really not used very much in this country, and I was impressed by that because in Europe and all, that's a very common modality for menorrhagia. And the reason given to me was because of insurance problems. It costs, Dr. James was telling me, more than $400, and plus provider time, and et cetera, et cetera. So most insurance companies do not cover levonorgestrel IUD insertion. But again, you can see some of them had plasma about 7%, and had about blood or exposure to blood or plasma product. Regarding hysterectomy, it was about 10% compared to about 26% in the previous study. So the implication is this is the largest study, and it provides insight into burden of disease and that hemostatic therapy may be underutilized. What about thrombotic disorders in females? Well, in the pediatric age group, we know that newborns and adolescents have the highest incidence. But then in women, if the childbearing age, there's a threefold increased risk of thrombosis during pregnancy. And of those, 50% have VTE, have thrombophilia. And one of the talks will be on, how do you do contraception in these women who already have a history of thrombosis? And recently I saw a young lady who has post-thrombotic syndrome, an adolescent girl, and she was wondering about, she wanted to get married and was wondering about contraception. And that's really a challenge. What kind of a contraception would you give to an adolescent who already had a history of thrombosis and has post-thrombotic syndrome? So hopefully we should be able to answer some of those questions. There is a CDC thrombosis registry with 6,058 patients, of which a little over half were females, many of them over 18 years of age and some below 18 years of age. And of those, 54% had, or almost 55%, had a history of VTE. And very interestingly, 434 had a history of poor pregnancy outcome. As you can see here, the location of the thrombus was different in those below 18 and those above 18. Upper extremity thrombosis was more common in the younger age group. And you can see brain thrombosis was more common in the younger age group. And as was like inferior vena cava thrombosis. We don't know how much of this was anatomic abnormalities. And that is a problem when we see children with inferior vena cava thrombosis, whether these are like May Turner or absent inferior vena cava. Should we do lifelong anticoagulation in these children or not? Those are issues that we need to address. And these are the risk factors. As you can see, trauma is more common in the adolescent as opposed to the older person. And cancer, of course, is seen in the older person. And very interestingly, obesity is common in both, although a little bit more in over the 18 years of age. Regarding thrombophilia, if you look at the numbers, there isn't really much of a difference. So you can see they're almost pretty much the same, whether it is factor V Leiden, protein C, antithrombin, or any thrombophilia. So what about women in race? And this was an abstract by Dr. Claire Phillip in ASH 2009 and was presented at last year's CDC Blood Disorder Conference. And what this shows is the difference between Caucasian and African American. And amongst these women, there were 407 women, 326 white and 60 black. And pregnant black women had more second trimester pregnancy loss, less factor V Leiden mutation, which we know, more protein S deficiency. And non-pregnant black women had greater BMIs, hypertension, sickle cell disease, and a family history of thrombophilia. VTE and MI were kind of less, MI was less common. When you look at genders, over the years, both males and females are at increased risk for thrombosis, a little bit more in males than in females. So somewhere we have maybe just a little advantage, but not too much. And what about pregnancy and thrombosis? This was a Danish study of 1,500,000 women and girls. And the incidence rate ratio of VTE compared to non-pregnant women increased over pregnancies. You can see it, I don't know how I can do the thing. It increased over pregnancy, reached its highest peak just before delivery, almost 21.5. And I think it says here, risk of VTE per 10,000 increased from 4.1 at week 1 to 11 to 59.3 in week 40, and then it fell down. And it really was not influenced by age or education. It just happened in all women. And just to point out, I was just reading a WHO report, there are 19 million adolescent girls worldwide who undergo or who experience pregnancy, 19 million. The most common countries in which these girls are present are Bangladesh, India, Nigeria, Brazil, and guess what? United States. I was really shocked at that. Of course, it didn't give any data on how many of these had bleeding disorder or pregnancy outcomes or thrombosis or things like that. But this is a huge problem regardless of what age group of women you consider. What about thrombocytopenias in these women? We just recently had a young lady who was my patient. I think it tells me I'm getting old because she became pregnant and she delivered a baby. She had ITP, chronic ITP, and her baby, even though they say maternal ITP causes very mild disease in in their neonates, well, this baby was born with the platelet count of 4,000, so it really wasn't all that mild. But anyway, thrombocytopenias can be inherited or acquired, and gestational thrombocytopenia is seen in 10% of women. So this is just to show you that about 10 to 16% of adolescents with thrombocytopenia have menorrhagia. And just yesterday, we had another young lady with chronic ITP who had very heavy periods. Her hemoglobin dropped to like 8 grams or so. And we were having difficulty in getting IVIG because her platelet count was like 34 or 35,000. And the pharmacy is very restrictive about its use of IVIG because of the cost. And they were arguing with us saying that, well, her platelet count really doesn't match. And I'm like, wait a minute, she's bleeding. So that should be the indication, not a platelet count. But anyway, ITP can be seen in pregnant females, and there are fetal effects that can occur. So here is the etiology of thrombocytopenia in pregnant women. This is a slide courtesy of Andra James, and gestational is the most common one of the thrombocytopenia, followed by preeclampsia and immune thrombocytopenia. What about sickle cell disease? Well, delayed puberty is a major problem, as I mentioned before, and then decreased bone mineral density is seen in prepubertal females. Pregnancy, the mortality, even though it's less, a lot of them undergo cesarean delivery. They have crisis, pulmonary hypertension, preeclampsia, pneumonia, pyelonephritis. So you can see a list of all these problems that occur in these females. This is one of my pregnant adolescent patients with sickle cell disease who did go through a lot of pain and pulmonary hypertension during her pregnancy. And then there is always the question of the use of hydroxyurea. Should we be using this? Shouldn't we be using it? And I don't think the literature is there anywhere to either support it or say that it should not be used. But more of a problem is the fetal effects. As you can see, besides an affected newborn, you have other fetal effects such as IUGR or intrauterine growth restriction, stillbirth, perinatal death, narcotic withdrawal. I mean, this is a huge problem because many of these patients with sickle cell disease are on narcotics, and so when their babies are born, one has to worry about narcotic withdrawal. And alloimmunization is a big problem in some of these patients because the mother has been exposed to so many blood and blood products, and so the baby may be at risk. And again, there is hardly any literature on these. So I just bring these issues saying these are things we should be looking at. This is a slide of these girls at a festival in India, one of my favorite, called Holi. And in that festival, you throw colors at people. And it's a conquer of good over evil, awareness over ignorance, whatever. It's everything great and happy and good. And so I think we have done a lot for women with the blood disorder, but there's still a lot needs to be done. So we know that it's a significant health problem. Maximum impact is in childbearing age, and there's a high incidence of adverse pregnancy outcome. And preconception care, and Dr. Hani Atrash is a big proponent of preconception care, may prevent pregnancy outcomes, and research is really needed in defining perimenopausal and menopausal issues in women with blood disorder. So yes, we are going there, okay? And I want to acknowledge my friends at the CDC, Peter Quides, Dr. Usha Reddy, who has done some of the animations, and all the women and girls with blood disorders. And this is a young girl with sickle cell disease. For years, the mother would not give her hydroxyurea, and she came in almost month after month with acute chest syndrome, pain crisis, etc. Then finally, my colleague, who has a daughter with sickle cell disease, convinced her. The daughter has perfect school attendance. So this young lady took hydroxyurea, and then she ran a marathon and won it. So I just want to thank my colleagues and all. So thank you very much.